You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 4th, 2025. This week, ACC and ERA reviews, including the Warrior trial, TAVI, DAPATAVI, and the SOUL trial. First up, some comments. As I said last week, I would be at the European Heart Rhythm meeting instead of ACC. The European Heart Rhythm is a great meeting. I had to give a debate against PFA, against one of the most experienced PFA doctors in the world, Dr. Boris Schmidt from Frankfurt. The trouble is, I had to admit to the audience that I was now a PFA convert. I haven't actually done a thermal AFib ablation in 9 months. So what I did instead during the debate is to pretend that I was a neutral Martian, and I tried to give an unbiased review of the actual evidence, which is decent for PFA, but far from definitive. Now, more on PFA next week because there was a big trial of PFA versus cryoballoon presented at ERA. Now I want to express my thanks to the many people who came up and said they listened to the podcast. Gosh, there were so many countries represented, too numerous to even list. It means so much to me that when you say hello. Another great thing happened at ERA. The organizers set up a 5K. And thanks to the ERA president, Dr. Helmut Purfuner, for running with me, but sorry for slowing you down, Helmut. Finally, I was happy to speak in a session at ERA on critical appraisal. Now, despite the time of 4 o'clock, the room was full, standing room only, actually, people standing in the back. And that's encouraging that so many people were interested in learning this crucial skill. Remember, friends, the more you know about critical appraisal, the more immune you will become to being bamboozled. Now, from ERA, I flew to Amsterdam, and I've spent 2 days here at the University Medical Center Amsterdam team. And first, what an impressive place. The hospital is huge, and within the walls of the hospital are basic science labs where researchers intend to sort out causes of AFib and also master radiotherapy for VT ablation, among other things. These are very thoughtful and impressive people. Now, to my American colleagues in structural cardiology, I watched a 20-minute TAVI procedure, and they did it while they were talking to the patient, wide awake, 1 arterial puncture. It was faster than most AF ablations. Now, this is one of the greatest advantages of traveling to seeing these vastly different approaches to the same problems. Mostly, when you visit cost-constrained systems, you see what is possible with streamlined approaches. And to my intracardiac echo enthusiast for AF ablation, the Dutch do not use it, and my guess is that our outcomes are not any better than Dutch outcomes. My final comment, then I will get to the papers, I promise. I want to thank the UMC Amsterdam team for such a great visit, which included a 55-kilometer bike ride around the beautiful countryside east and south of Amsterdam. All right, next topic is the Warrior trial. I noted Warrior in my ACC preview column because the study of this mysterious condition of ischemia with non-obstructive coronary disease, or IschemiA, it's a novel study and a great place to spend NIH money. Now, the results aren't formally published yet, so I'll keep the discussion brief. I want to focus on the concept of pragmatic trials, which this was. Now, all trials have some components of pragmatism, but Warrior was really quite pragmatic because it randomized women with IschemiA to either intensive medical therapy, high-dose statins and ACE or ARBs, or usual care. This was a large trial of about 2,500 women with symptomatic angina and no obstructive epicardial coronary disease. About half were diagnosed with a CCTA and the other half with angiography. The primary outcome was MACE, death, stroke, or hospitalization for angina or heart failure. Now, I would normally tell you the baseline characteristics at this point, but instead I want to tell you the results. The rate of the primary MACE events was actually higher in the intensive medicine arm. The hazard ratio was 1.13, 13% higher, and the 95% confidence intervals went from 0.94, a 6% reduction, to 1.37, a 37% increase. The p-value was obviously non-significant, and the fact that the point estimate and most of the confidence interval was above 1, pretty much excludes the chance that intensive medical therapy was better than usual care. And there were no significant subgroup or heterogeneous treatment effects of note. Now I want to go back to the baseline characteristics because I think this is key. Nearly the same number of patients were taking statins, approximately 71% in each arm. Nearly the same number of patients were taking high-dose statins, and quite similar numbers of patients were taking ACE or ARBs, about 53% in both groups. Now, another noteworthy finding was the tiny number of CV deaths, MI, and stroke and TIA events. More than 1,200 patients in each arm, and there were less than 15 CV deaths and MI and heart failure. The main driver of the endpoint was more than 300 events in each arm for hospitalization for chest pain. So one thing that we learned is that patients with NOCA who take these medicines may have lots of hospital visits for chest pain, but the number of heart events is very low. This was a non-significant result, but I don't think it tested intensive medical therapy because so many women in the control arm were on the same therapy. Now, this is called contamination, and it surely is a lot in this trial. And this is a common problem with pragmatic trials. When you study things in the real world, rather than with these strict trial protocols, you can end up with the two groups on similar therapies. And I don't think we learned anything from this trial, despite randomization and follow-up of 2,500 people. Money was spent and little was learned. I would not conclude from this that intensive medical therapy is not helpful. You can't say that. I would say that since both arms got essentially the same therapy, I think the only conclusion is that you could say that the trial procedures preclude knowing anything about this intervention. And the biggest lesson from this trial is to be wary of super pragmatic trials. I used to think that we could just randomize people within the realm of real-world practice and then measure outcomes without strict protocols. And doing so would perhaps be more representative of what we see in real life. But the problem, of course, with this approach is the noise and, like, contamination in this trial. And patients in the control arm are free to take whatever they like. And in this case, they took high-intensity statins. Now, I've come around to the idea that trials should be at least somewhat restrictive with their protocols. And now that might make a trial a special environment with special patients. That might make external validation or translation to the clinic harder. But at least with such a restrictive trial, you can test two disparate strategies and learn what the effect is in that environment. The author's discussion of the trial procedure issues will be interesting when the paper is published. Okay, the next topic is the BHF Protect TAVI trial. This was a great effort and a great trial. It was a large trial as well. More than 3,800 patients were assigned randomly to have TAVI with the Cerebral Embolic Protection Device, or CEP device, and about 3,800 patients had TAVI without protection. Now, the CEP device is known to catch debris. The pictures are impressive. This debris would have lodged in the brain and caused stroke. The results of this RCT in the UK are clear. 2.1% of the CEP group had stroke, the primary outcome, versus 2.2% in the no CEP group. 2.1 versus 2.2%. And the actual numbers of patients were 81 and 82 patients in each group. Now remember, these were 3,800 patients in total. So nearly the exact same outcome. The absolute difference was minus 0.02, and the 95% confidence intervals, which I'll come back to, went from 0.68 to 0.63 positive. The p-value was obviously almost 1.0. The p-value was 0.94. If there was no difference in outcomes, this p-value is completely not surprising. Disabling stroke was 1.2% versus 1.4%. Death was 0.8 versus 0.7%. Adverse events were similar. The authors also performed a special type of analysis called a complier average causal effect, or CASE. This is the first time I've ever seen this, and so I'm not an expert here, and I'll probably get it not exactly right, but this is an instrumental variable analysis that attempts to mitigate bias when you look at a per-protocol type analysis. For instance, in this trial, about 81% of the CEP group had the device deployed as designed, but the trial was analyzed according to the intention to treat analysis. The idea here is that not everybody gets the CEP put in for the whole procedure, but they still count into the group that has the CEP device. Now, Dr. David Cohen helped explain this whole instrumental variable analysis to me. He also attached a beautiful explainer paper from Doctors Joshua Ankrist and Robert Ye and colleagues, and this is in New England Journal of Medical Evidence, and I will link to it. At the simplest level, you are basically dividing the average treatment effect by the difference in the rate of exposure to the treatment variable. So in the case of TAVI, you divide the ITT treatment effect on stroke, which is minus 0.1%, by the difference on exposure in the CEP device between the treatment and control groups, and that's 0.81, which equals 0.12% absolute difference, which is not different from the ITT. In other words, unlike a trial like Cabana, where the ITT and as-treated numbers were different, here the ITT and protocol treatment effects are similar. The authors concluded that routine use of the cerebral embolic protection device did not decrease the incidence of stroke during TAVI. So my comments. These results were similar to the protected TAVR trial, which had about 1,500 patients per arm rather than 3,800 in the PROTECT TAVI. And in that protected TAVR trial, they reported a stroke rate of 2.3% versus 2.9% in the control arm. Now, one positive from this negative trial was a signal of device benefit for disabling stroke. In protected TAVR, it was 0.5 versus 1.3%. Now, it also appears that observational studies largely predicted these findings. Namely, Dr. David Cohen again, who I've talked to a lot about this, and colleagues, they did an observational analysis using the STS-ACC TVT registry to compare outcomes after TAVR with and without embolic protection in more than 400,000 patients. Obviously, this is not a controlled, randomized controlled comparison. Now, in a clever design that they used, using an instrumental variable analysis with site-level preference for device used as the instrument, they found a 13% statistically significant reduction in disabling stroke and a non-significant 10% reduction in all strokes with a device. This result suggested rightly, I think, that PROTECT TAVI would A, have a very low rate of stroke, and B, likely be underpowered. That is because if you assume from the observational study that I just mentioned that stroke rates would be about 3%, they were slightly lower actually at 2.2% in the BHF trial, and you assume a relative risk reduction of 10%, a trial would have to have more than 100,000 patients to detect that difference. Indeed, in the PROTECT TAVI trial, the 2.1 versus 2.2% stroke rates yielded a risk ratio that was 0.99. But the 95% confidence intervals went as low as 0.73. That would be a 27% reduction of stroke, and 1.34, 34% risk increase. That's kind of weird, isn't it? The trial has 3,800 patients per arm, but because stroke rates are so low, the confidence intervals are wide. And given that wideness, you'd have to say the trial is not strongly informative. The device could have a very significant 27% reduction or 34% risk increase within the confines of that 95% confidence interval. And that same comment holds for disabling stroke, which was even lower in incidence at 1.2 versus 1.4%. Here, the risk ratio was 0.89, but the 95% confidence intervals went to 0.60, a 40% reduction, to 1.31, a 31% risk increase. Now, while the 95% confidence intervals are wide, I think we can learn a few things relevant to stroke protection during TAVI. You can say that the total stroke and disabling stroke rates in both trials are very low without protection. When an outcome is that low, it's always going to be hard to make it go even lower. You'll need huge numbers of patients. Even meta-analyzing the two trials will still lead to small numbers and I think a minimally informative pooled effect. And that in and of itself is instructive. We can conclude, therefore, that since stroke rates are so low after typical TAVI, it's hard to justify placing this costly device that requires another arterial access and manipulation into carotid arteries. I would think that CEP devices would be rarely, if ever, used based on this data and the data combined with PROTECT TAVR. Okay, I have another TAVI trial to talk about called DAPATAVI. This was an RCT comparing dapagliflozin after TAVI to TAVI alone. New England Journal of Medicine published the late-breaking clinical trial that was presented at ACC, but before I tell you anything, I want to make note of the fact that the presenter came out on the ACC stage with quite loud music, upbeat music playing. I put my Shazam app on it, and it turns out it's Danza Kuduro, a Spanish-Portuguese song by a Puerto Rican artist named Don Omar and Portuguese-French singer Lucenzo. The song became a hit in many Latin American countries. The audience of presumed scientists stood and began clapping to the beat before the presenter said anything, and the presenter did a little dance as well. Now, I'll come back to this business later after I tell you about the trial. Now, to be included in the DAPATAVI trial, patients had to have a history of heart failure or one of the following: CKD, diabetes, and LV dysfunction. That's in addition, of course, to their AS and the TAVI. The primary endpoint was cardiovascular death or worsening heart failure defined by an urgent visit at 1 year. So this is a typical heart failure endpoint, right? CV death and heart failure events. Patients were older. These were 82-year-old patients. Half were female, ejection fraction mildly reduced at 47%, and an eGFR around 56. Slightly more than 70% of both arms were on a diuretic already. About 600 patients were included in each arm. The primary outcome of CV death or heart failure event occurred in 15.0% in the DAPA group and in 20.1% in the standard care group. That hazard ratio was 0.72. 95% confidence intervals go from 0.55 to 0.95, and the p-value calculates to 0.02. As you would expect, the driver of the primary endpoint were heart failure events. CV death and all-cause death were not significantly lower. Most of the heart failure events were, quote, urgent heart failure visits. As usual, the authors don't tell us total hospitalizations, which drives me crazy. So, my comments. The trial was investigator-initiated, and industry at least did not fund the trial directly, which is good. Also good is that it enrolled older patients. Few trials have patients that have a mean age older than 80. Also good was that half of the trial included women. Now, the primary endpoint was a positive result, but I think there are serious limitations that preclude having a new indication for routine use of SGLT2 inhibitors after TAVI. One limitation is that the driver of the primary endpoint was a bias-prone heart failure event. And it's especially troublesome here, as the authors note that the trial was open label, without a placebo tablet. Thus, patients and caregivers knew their treatment assignment, and that knowledge may have affected clinical decisions. Namely, the decision to just add some oral diuretic over the phone and not have a, quote, heart failure event, versus have the patient come in for a heart failure visit or heart failure hospitalization. Second, like so many of the SGLT2 inhibitor trials, the drug does not reduce CV death or all-cause death. It therefore, I don't think, can be called a disease-modifying drug. Now, perhaps a longer follow-up than a year may have led to a lower death rate in the drug arm, and the short duration of the trial is also a limitation. The authors do not present total hospitalizations. This is an important outcome because these are 82-year-old people with multiple comorbid conditions. A heart failure hospitalization may represent only one cause of hospitalization, and if total hospitalizations are not reduced by the drug, then that would further lessen my enthusiasm for this treatment. Note to heart failure trialists, please report all-cause hospitalizations in these trials. Now, many of these patients had SGLT2 inhibitor indications like a modestly lower EF, diabetes, or CKD. For those types of patients having TAVI, I would say fine, use SGLT2 inhibitors. But these results I don't think are strong enough to warrant a new indication for the drug. Once again, I want to say that I love trials. I think we need more trials. I also really appreciate the clinicians who do trials. They have my respect. And this trial was investigator-initiated, which is great, but the issue is that if we are going to use the results to start a new practice, the trial procedures have to be robust and all important outcomes reported. Here, the lack of blinding, the short follow-up, and no report of total hospitalizations, which precludes assessment of competing risks, weaken the ability to use this trial to change practice. Finally, a note on the music before the presentation. It was a nice song, but it is out of place in a presentation of science. I'm sorry, but that's the way I feel. All right, next topic is the SOUL study. This was oral semaglutide and CV outcomes in patients with diabetes, also published in the New England Journal of Medicine. We know that GLP-1 drugs have shown benefit in patients with diabetes, CKD, and atherosclerotic cardiovascular disease with obesity. Now, these were injectable GLP-1 drugs. There was one trial called the Pioneer 6 trial of oral semaglutide versus placebo in patients with diabetes, and this established non-inferiority and cardiovascular safety. The SOUL trial, presented at ACC, set out to establish the efficacy of the oral drug GLP semaglutide. Now, this was a big Novo Nordisk-led trial, industry-sponsored trial. Patients had to have diabetes with elevated hemoglobin A1C and at least one of the following conditions: CAD, PAD, or CKD. Patients with end-stage renal disease were excluded. Patients were then randomized 1-to-1 to oral semaglutide or placebo. Doses started low and then were escalated to a maintenance dose of 14 milligrams daily. The primary outcome was a 3-point MACE of CV death, MI, and stroke. There were many secondary outcomes reported. Now, this was a large trial of 9,600 patients, and it was randomized in 444 sites in 33 countries, and that must have been a heck of a thing to keep track of. Mean age was 66 years, and about a third were women. The mean follow-up was quite long at nearly 4 years, and the main trial result was positive. A primary outcome event of a 3-point MACE was 12.0% in the oral semaglutide group versus 13.8% in the placebo group. That hazard ratio is 0.86. It's a 14% reduction. The confidence intervals go from 0.77 to 0.96, and the p-value is equal to 0.006. In person years, it was 3.1 events per 100 person years versus 3.7 events per 100 person years. So in absolute terms, that is about a 1.8% absolute risk reduction, or an NNT of 55 patients. Cardiovascular death was 6.2% versus 6.6%, and that's not statistically significant. MI was the driver, 4.1 versus 5.6%. That's a 26% reduction. And the confidence intervals there were below 1, 0.61 to 0.89. Stroke was 3.0 versus 3.3%, not significantly different. Death from any cause was 10.9 versus 12.0%, lower but not significantly different. Heart failure events, 3.0 versus 3.5. Major kidney events were non-significant. The mean body weight was approximately 3 kilograms less in the semaglutide group. Adverse events that led to permanent discontinuation of the drug occurred in 15.5% in the semaglutide group versus 11.6% in the placebo group, and such events were mainly GI. The authors concluded the right conclusion was that the drug was effective at lowering cardiovascular events. And for my comments, I will just simply say that this was a positive trial. The primary endpoint was positive, mostly driven by lower rates of the MI in the semaglutide group, but all components of the endpoint and kidney outcomes were directionally better on semaglutide. The secondary composite kidney was lower on semaglutide, but it did not reach statistical significance, so the authors, by their own rules, did not test components of that endpoint or anything underneath that endpoint. And the authors spent time in the discussion explaining why the kidney outcomes were less impressive than, say, in the FLOW trial. And one explanation could be that the FLOW patients started with a much lower GFR, but another explanation, and this is interesting to me, could be the much lower bioavailability of the oral versus the injectable GLP-1 agonist. The safety profile of oral semaglutide looked fine, and it looks similar to other GLP-1 drugs. Notable, I think, was that about 25% of this population of diabetic patients were on SGLT2 inhibitors. And for the purposes of translating this evidence, the inclusion criteria required established heart or kidney disease, but remember that many patients with type 2 diabetes do not have these conditions, and I don't think the results would necessarily apply to them. The mean BMI of these patients was 31, and the weight loss was only 3 kilograms over 4 years. I have to say, though, that the effect size was modest, right? A 14% relative risk reduction. The absolute risk reduction in non-fatal outcomes of 1.8%, an NNT of 55 is decidedly modest. The p-value is persuasive, and since the trial is directionally consistent with other GLP-1 trials, I suspect it is a real finding and not noise. Now, I don't know enough about diabetes management to know where oral semaglutide will fall into the regimen of the many other diabetic drugs. I will say that at quick glance, the degree of weight loss seems less than the injectable drugs, but on the other hand, patients may be more accepting of an oral pill rather than a weekly injectable. We shall see. Now, the next topics will have to wait till next week. I will have more ACC and ERA recap, including the big PFA versus cryoballoon trial from Swiss authors, as well as the fluid restriction trial. This week, I'm recording from my Amsterdam hotel room, and I have a relatively early flight to catch, so next week's program will be more extensive. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And to all the people who came up to me at ERA to say they listened to the podcast, I really appreciate it and thank you. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.